Hey everybody, welcome back to the ECG of the day. My name is Reid, and don't forget that you can download this PDF document down, linked in the description below for your own viewing pleasure and note-taking. And don't forget to subscribe to the channel if you enjoy this content and like the video if you like the video. So let's jump into it. So first thing we're going to do is look at the force and get an idea of what's going on with our rhythm. And so maybe I'll start down, maybe V1 has got kind of the best morphology for you guys to see. And so I noticed that I've got a wide complex QRS. It's a wide complex rhythm. And it seems to be quite regular. You can see that regularity extends throughout the entirety of the rhythm. The rate here, I'll just pick maybe, here is a QRS, that kind of that S wavelength right before that solid line. So 300, 150, 100, 75. So 75 beats per minute. Okay. I glance really quickly and I see that there seems to be a sinus P wave before my nice QRS. Let's evaluate that P wave. Okay. So first thing I think of with a wide complex rhythm is this a ventricular rhythm, right? We think of why is it wide? Well, it's wide because it's not taking, it's either coming from the AV node and it's not taking the normal His-Purkinje system, or it's coming from the ventricles and conducting aberrantly, right? Wide means taking too long, not taking His-Purkinje system. So why is that? Well, if we have P waves in front of it, then maybe it's some type of bundle branch block, right? But let's evaluate those P waves and make sure that it corresponds with how we would expect P waves to be. And so if you look, we see we have a P wave that's like isoelectric, maybe even just a hair positive in lead one. I mean, this slide is right. You can see the next one's like right there. So slightly positive. But we've got positive P waves in AVF, and we also have got positive P waves in lead 2. This all tells me that my P waves are coming down and to the left, which is normal for a sinus P wave. Okay, next thing in our conduction system is our PR interval, which really represents the AV node. How is our AV node functioning? And so I can measure my my PR interval here. I can see my PR interval is within 120 to 200 milliseconds, or 3 to 5 small boxes. And so that tells me that it's delaying that signal appropriately for my ventricles to fill. But that's only one beat that we just looked at. So sometimes I like to kind of scan through the entire rhythm, right? Just kind of throughout the rhythm and make sure that every P wave has a QRS and that they all conduct in the same fashion, and that there's not any P waves that are like hidden on these ST segments and T waves previously that were dropped that we were missing, right? And a good way to see if there's any drop P waves is if there's sometimes a pause in the rhythm, then you might think, maybe that's the case. But that's not the case here. Next thing we're going to do is we're going to evaluate how things are conducting through our QRS. So what is our QRS doing? So we notice that if we mark the start of the QRS, and it's like 4 small boxes. So my QRS duration here is 4 times 40 milliseconds, which is 160 milliseconds, which is too long, right? We think 120 to kind of be the upper limit of what we want. And so if we think that this rhythm is coming from the SA node, like we said, being delayed by the AV node, like we said, and sent down to the ventricles, well, there must be some type of bundle branch block to explain our wide complex QRS. So the first thing I notice is that my QRS axis is upright in lead 1, but it's downright in AVF, downgoing in AVF. So we've got a QRS axis that is up and to the left, right? So we've got left axis deviation, right? It's negative in lead 2, so it's got to be going away from lead 2, so it's going that way. Right, so we've got left axis deviation, and so now we need to explain that left axis deviation. Well, I wonder if there's a left bundle branch block. Well, what would left bundle branch blocks look like? Well, it would be late signals. So later on in the QRS, the thing that's causing the QRS to be wide, if the left bundle branch was blocked, then we would get late signals going towards the left side because the left bundle didn't do it for us. And so if you look in lead 1, you see we've got this R prime. All right, so in lead 1, we've got late signals in the form of that R prime. You can see it also in AVL, right? R prime, right? And those are our lateral leads 1 and AVL. So that makes sense for a left bundle branch block. And same thing, we have it over here in our lateral V6, right? R prime. That's another R prime. Right? Remember, we get R primes because when signal comes down from the AV node down, and it splits into my left and right bundles. If my left bundle branch is blocked, it'll go down my right bundle nicely, and it'll depolarize the right side in a rapid fashion. And in order for the signal to depolarize the left side of the heart, it's got to go from cell to cell gap junction slowly. This takes forever, right? And so look at the direction of those slow, late forces. They're going straight towards my lateral leads, right, and V6. So that's what we get. We oftentimes get loss of our septal R wave. This time we didn't completely lose our septal R wave. Right? Remember, the left bundle is responsible for depolarizing the septum, which is usually towards V1. So if it gets blocked, we can lose that septal R wave. However, it really just isn't. It depends on the anatomy, right? Some people, the left bundle branch can be blocked distal to some of those fibers that dive into the septum, right? So there's just plenty of reasons why we might still maintain a little bit of a septal R wave. That's okay. So what do we have here? We've got a left bundle branch block, right? That explains everything. And let's take a look at our QT interval, right? I like to take maybe 2 R waves here, find the midway point, and make sure that my T wave ends by that point, which it does. So I've got a normal QT interval based on the rate, right? It's all rate related. Last thing I'm going to do is look for pathological Q waves, which tell me if there's any previous myocardial infarctions that are represented by the first deflection of the QRS, or the Q wave, being distinctly negative compared to the remainder of the deflections, and we don't have any. And then I look for ST elevation depression, any T wave abnormalities. Remember, in left bundle branch blocks, if you look for ischemia or infarction, you use something called the Scarbosa criteria, right? And these are used in left bundle branch block to evaluate for infarction. Okay. And so I don't see any of those changes here, right? And those are just because we know that when there are depolarization abnormalities in the left bundle branch block, there are also going to be repolarization abnormalities that are going to affect my ST and T waves. So we need to account for that when we're looking for infarctions. And so we put this all together, and what do we have? We have a sinus rhythm at a rate of 75 beats per minute. We have left axis deviation and a left bundle branch block. So hope this helps. If you have any questions about the physiology of this ECG, let me know. Hope it better helps you understand kind of what's going on with this person's electrical kind of conducting system, and you can evaluate, their symptoms and what's going on, right? We got an ECG for a reason. So, alrighty, have a great rest of your day. See you on the next ECG video.